Thank you very much for the opportunity to participate in the GIS conference. The title that I have been given is Left Main Bifurcation, Simple versus Structure. I will consider it as a two-stage approach. My name is Cheem, and I'm from the National University Heart Center, Singapore. I think when we consider PCI of the left main artery, there are certain unique considerations pertaining to this particular lesion. The left circumflex, which is a side branch here, has a large reference diameter and angulated, making it difficult to access with guide wires. The bifurcation angle of the left main stent often affects the implantation technique. The acute occlusion of the left circumflex side branch can result in considerable ischemia, and left main is the only bifurcation where the proximal main branch originates directly from the aorta. And this increases complexity because of the interactions with the guiding catheter and the potential for guide wires to go behind the left main stent struts. I think the questions of whether we should perform simple versus a complex two-stent strategy for patients with left main disease can really be gleaned from the data provided by two trials that were performed in the last 5 years. The first trial is the EBC main, which was performed in published in 2021. And the second trial was much earlier. It's called the DK Crush 5, which was published in 2017 in JACC. Let's go to EBC main and look at the study hypothesis. Now, EBC main was designed to examine the clinical outcomes between two different strategies. One is that of a stepwise layered provisional strategy versus a systematic dual stent strategy. The primary endpoint was death, target lesion revascularizations, and myocardial infarction at 1 year. The secondary endpoints were death, myocardial infarction, and TLR, as well as stent thrombosis. Now, when you look at the EBC main, there's actually quite a well-defined strategy here. A provisional approach requires that the operators go by a step-by-step layered technique. PORT, which is proximal optimization technique, is mandated, and kissing balloon inflation is also mandated in this one-stent strategy. Systematic approach, however, the techniques is up to the operator's decisions, and whatever the approach is taken is according to the EBC consensus. High pressure osteobifurcation and kissing is also mandated in the systematic approach. Now, I'm not going to go into the details of step-by-step provisional technique, but suffice to say that when you implant a stent in the main vessel, you want to size it according to the distal main vessel size, followed by a port according to the proximal vessel size. And kissing balloon inflations using short balloon is actually required in this particular technique. Now, when you look at EBC main being a randomized controlled trials, the patients were quite well distributed between the two strategies. But what is obvious is that the number of stents implanted and bifurcation, the stent length, the procedural duration, the fluoroscopy time, as well as the radiation exposure are also expected to be higher in the systematic dual stent strategy. And what is also interesting is that in the provisional stent strategy, there were 22 patients who actually cross over to the systematic dual stent strategy. And for those who actually cross over, 50% of the techniques employed were keloid, and the other 50% was TEP. So none of the crossover actually involves a DK crush, because it's actually not possible to do a DK crush as a crossover build-up strategy. As for the systematic dual approach, majority of the European operators chose keloid, which is 53%, and this is actually followed by a TEP technique, which is 33%. DK crush remains unpopular among the operators in this particular study. When we look at the primary endpoint here, there's actually no difference between stepwise provisional approach versus systematic dual approach with regard to the death, myocardial infarction, or target lesion revascularization. The stent thrombosis in both arms are also very low at 1.7 versus 1.3%. So the conclusion from the EBC main was that the stent treatment of true bifurcation left main disease generally had good outcomes. There were few adverse events. Procedural time, X-ray dose, and consumables were also less in the provisional approach. And only 1/5 of the patients in the provisional group requires a second stent, a crossover. So the operators, investigators' conclusion is that it's not necessary to prejudge the issue, just start with a non-provisional two-stent approach. And patients generally are treated quite well with a stepwise layer provisional approach without any price to pay. And it should remain the approach of choice for treating patients with left main bifurcation stenosis. But that's left main, EBC main. But we also know that the study had significant limitations. First of all, it was designed to be a superiority trial, so it was not a non-inferior trial. So the number of event rate was actually lower than what was calculated. So it was 14.7% in the one stent group versus 17% when the actual event for the two stent group was thought to be 25% compared to the 17.7% which was observed. So this gives us the possibility that there may be a type 2 error where the difference is not actually observed because of a small sample size. There was also non-uniformity in the procedure. Although mandated in the protocol, not all patients had port in both groups, and no kissing balloon inflation was also performed in 11% in the provisional stent strategy. And there was also a no second stent in the two stent group in about 5% of patients. And finally, 5% of patients had appropriate cardiac enzymes measurement, which may impact on periprocedural myocardial infarction rate. And finally, there was slow enrollment in this particular trial of 3.5 years among the European centers. 4 patients per centers were enrolled per year, so there were very low operator experience with regard to complex left main PCI. Now, if you look at the other trial, which is DK Crush 5, this is a trial obviously employing the strategy of DK Crush stenting, which is a 7-step procedure first devised in 2003 following the experience with the classic crush, where there was a high incidence of field side branch crossing. So Dr. Chen from China has came out with this DK Crush. And so this DK Crush technique has actually spent around about 16 years in terms of clinical trial evaluation. The first trial to evaluate DK Crush technique in left main was actually DK Crush 3, where this is a technique that was compared with keloid stent technique in patients with distal left main bifurcation. At 3 years of clinical follow-up, you can clearly see that there were higher MACE in the keloid group compared to the DK Crush group. And when you look at the baseline characteristic of the DK Crush 5, which is a strategy of provisional stent approach versus that of a DK Crush 2 stent approach, designs pretty much like a EBC main. What is clear here is that the patients here are also quite well matched in terms of its distribution. But for the first time, we have what we call a complex bifurcation lesion definition in this particular study, where patients who fulfill certain criteria as outlined in the definition 2 trial can be classified as a complex bifurcation lesion. Now, DK Crush 5 results are quite different from that of a EBC main in the sense that the DK Crush 5 was found to be superior in terms of a reduction of primary endpoint compared to DK Crush in the provisional approach. So the absolute difference was nearly 5 or 100 times, twice that of the DK Crush rate. So when you look at DK Crush and you think that it is quite a superior trial in favor of DK Crush, but there are also limitations in DK Crush 5. It is also a underpowered study. What is amazing here in the 2 stent strategy here is that the procedure times is certainly longer, it's 16 more minutes, and take about 19% or nearly 20% longer compared to a provisional approach. And that 47%, nearly half the patient in the provisional group, actually require additional side branch stent. So they require a crossover to these to the 2 stent strategy. And for those patients who actually cross over to a 2 stent strategy, you find that they were associated with much higher incidence of target lesion failure for those who did not cross over, and much higher incidence of stent thrombosis of up to 6.1% when the 2 stent strategy was employed as a build-out in the DK Crush 5. So it was quite clear that the majority of operator who chose a build-out for the provisional group chose the TAP technique, and you wonder whether these operators are familiar with the TAP technique. Certainly, there were a lot more attention paid to the performance using a DK Crush technique compared to the techniques. So how can we what can we draw from the differences between EBC main and DK Crush? Let's look at the direct comparison here. Both are superiority trial. Both have an estimated of about 450 as a sample size. However, in the EBC mean, they were looking for a much less complicated group of patients. So syntax score has to be less than 32. DK crush has got no limits with regard to complexity. CTO is excluded for EBC mean. AMI has to be more than 72 hours. For DK crush, as long as it's more than 24 hours, MI is okay. As long as you can cross the lesions, patients can still be enrolled even if they have CTO. So DK crush technique is, of course, the 100% choice in the two-stem arm, whereas it was a mixed bag of two-stem strategy in the EBC main systematic dual strategy approach. So when you look at the number of PCI performed by the operator in the EBC main, it was about more than 150. But when you look at the DK crush operator, we are looking at people who are doing high volume, more than 300 cases, of which left main PCI constitute about 20 cases per year. When you look at the syntax score here, clearly you can see the difference, 23 versus 31. Side branch lesion length is 7 millimeter versus 16 millimeter. And complexity, there were about 30% of patients with defined complex left main bifurcation stenosis. So when you look at the procedural outcomes here, is quite stunning. While there was no difference between the primary endpoint between provisional and two stents, you can see that in the DK crush arm, in the DK crush 5, the primary endpoint was 5% versus 10.7% in the provisional group. What is also stunning here is that this is the lowest stent thrombosis rate that we can see in patients with left main PCI using two stent, 0.4% versus 1% in both the provisional and two stent approach in the EBC main. For the DK crush, it is quite alarming that the provisional arm actually has a 3.3% incidence of stent thrombosis. What is also interesting here in the DK crush 5, when you break down in the lesions into both simple versus complex, it is quite obvious here that the complex lesions are the one that benefited from a two-stent strategy. The simple lesions did not benefit from a complex two-stent strategy approach. So what is my personal perspective from EBC main and DK crush trial? First of all, now we know that PCI of left main needs to achieve a good result, something that will last as good as that of a CAPG. I don't agree with the EBC main concept of a no need to prejudge an issue. I still think that we need to preempt any potential issues in our PCI to avoid a bailout situations. Stent thrombosis in left main PCI is low. In the EBC main, undifferentiated between provisional versus two stent group, and that stent thrombosis is high in DK crush 5 provisional group. There was significant difference in the two stents outcome, EBC main versus DK crush, 17.57 versus 5%. Is this a issue of a stent technique, or is it a problem with image guidance? But both groups will have IVUS only about 40% of patients. Is it the situations of operator volume relations or the length of follow-up? And finally, it would appear that the attention to detail with regard to the specific technical aspects of each procedure is slightly different in the two studies, and the results may have varied as a result. So I like to look at this approach to a left main intervention using this Dr. Rapp's algorithm here. And he says that in patients with left main bifurcation lesion, and if this lesion turns out to be a complex one, then you should go directly to a two-stent approach, and preferably using a DK crush as in the Asian Bifurcation Club consensus. And IVUS or OCT imaging is highly encouraged. But if the left main bifurcation lesion is simple, and when we say simple, lesion's diameter is less than 70%, lesion length is less than 10, and you think that the side branch access is not a problem, then you can just go and do a provisional approach and like the EBC consensus. But if you think the side branch access is a problem, then perhaps we should just go straight to the two-stent approach, even if this is a simple left main bifurcation stenosis. So in conclusion, Mr. Chairman, ladies and gentlemen, I think the stent treatment of true bifurcation left main disease is a safe one in current days and effective. The provisional approach, simple versus a complex two-stent treatment strategy, should be individualized according to the lesion morphology. And certainly we have to consider the complexity of the lesion when deciding on this treatment. So the EBC main and DK Quach actually share certain commonality, and that is for simple lesions, perhaps one stent strategy is good enough. Two stent strategy is for highly complex stenosis. At the end of the day, it is always going to be the operator's knowledge, skills, and experience that will really decide on the outcomes of the patients who underwent PCI of the left main stenosis. Thank you very much for your attention and this opportunity